A graduate student told me people are doing this microdosing, taking very low doses of LSD, and they're reporting all kinds of beneficial effects. But no one had really looked at it systematically under controlled conditions, and that's what I do.
Welcome to Mind, Body, Health, and Politics. I'm your host, Dr. Richard Lewis Miller. Today, I have the great privilege of having with us here on Mind, Body, Health, and Politics, Professor Harriet de Wit of the University of Chicago. For those of you who are not already familiar with her work, she has a long and distinguished career in science, and in particularly psychedelic science. Welcome to Mind, Body, Health, and Politics, Harriet.
Thank you. It's a pleasure to be here.
Harriet, how long have you been working specifically in the area of psychedelic science?
I've been working in psychoactive drug research for many years, for probably 40 years. But I only kind of ventured into psychedelic drugs in the last maybe 10 or 12 years. So I did a lot of work with drugs that have some potential to be misused, or used for non-medical purposes. And one of those drugs that I spent a lot of time studying was amphetamine and amphetamine-like drugs. And then when MDMA came into the news, it was a kind of a natural progression for me to study this MDMA, which is in many respects like a stimulant drug, but has some unique effects of its own. And my studies this research I do is kind of laboratory-based, highly controlled studies. And we're in a very good position to then test the effects of this relatively novel drug, MDMA, or that people hadn't been in the mainstream of research. So that got me interested.
Well, we're going to focus on the psychedelics today. However, since you have mentioned your research in methamphetamines, I want to take just a few moments to talk about that. So to begin with, what caught your interest as an esteemed scientist to study methamphetamine?
Methamphetamine is very similar to other amphetamines like D-amphetamine. They're basically the same under controlled circumstances. They're drugs that are being used in the treatment of several disorders, most notably ADHD. And they're also known to have some potential to be used recreationally or misused. And that's kind of where my research fell, that we're interested in studying those drugs that might be used medically, but that might also have some potential to be misused. So then we can ask questions like, what are the effects of the drug when people don't have expectations about what they're getting? So when we administer a drug, we don't tell people what type of drug they're getting. So we can look at how the drug makes them feel, how it makes them behave, and how it affects their brain function. And that's the sort of trio of measures that I've looked at with regular amphetamines, then with MDMA, and then most recently also with microdosing of LSD.
Well, one of the difficulties that scientists around the country are having with research on psychedelics is that when you give a placebo to one group and the actual medicine or substance to another group, it's extremely obvious who got what to the subjects right away, because psychedelics have such a large effect and the placebo is going to have no effect. So that's a difficulty for the scientists. Didn't you have the same difficulty with methamphetamine, that the people knew immediately which group they were in?
Actually, no, we were looking at low doses, and oral doses. So we're not looking at routes of administration that have high potential for abuse, like intravenous. We were giving the drug orally, and it turns out that at doses of 10 to 20 milligrams. And these are doses that just produce a feeling of well-being, and they're kind of within the range that people might experience normally, but they feel a little more energetic, a little more confident, and so we can measure the effects. they're relatively subtle, the effects, and they have a gradual onset. So people are not always able to correctly identify what drug they're getting in the case of the amphetamines, or at least the doses of amphetamine that we're looking at.
Okay, so it's the same as with psychedelics, namely, it's very dose dependent,
Absolutely.
very dose dependent. Okay,
Absolutely.
okay,
And kind of relevant to that, you were asking about the high doses of psychedelic drugs. That's difficult to blind them, and that's a problem that is haunting the field.
yes.
We don't know what an appropriate comparison would be. Some other strong experience, some other drug effect that isn't specifically these drugs. So everybody's struggling trying to find an appropriate control. I've gotten into the psychedelic research at a slightly different point. I'm studying microdoses, so very low doses at sort of the threshold of detectability. And there we have less of a problem with the placebo, although it also kind of it's also an obstacle in the work that we do with these microdoses.
Okay, a little bit more on amphetamine before we go into psychedelics. From your research over the years on amphetamines before you switched into psychedelics, give us some of the headlines that perhaps the public might benefit from knowing about your research with the amphetamines. Do you have a few headlines?
Let's see. I guess there are some misconceptions about amphetamines that, at least at the doses that we're administering in the laboratory, that they produce a kind of a feeling of confidence and well-being, and in some cases actually calm. So the kind of conception is that they're going to make you agitated and nervous. That might happen at very high doses, but it's the drugs that we're administering, kind of, to, I guess, to my surprise and contrary to some people's expectations, they help people to focus. You know, they help people with ADHD to focus. They also help healthy volunteers to pay attention, to focus, to exclude kind of extraneous stimuli. So I guess I would say we're characterizing the effects of the amphetamine. We're also interested in who might be at risk for liking the effects a lot. So we look at their responses in relation to personality. So we look at the people's acute responses to a single dose of the drug by these measures, how they feel, how they behave. And then we can look at whether men and women differ, whether it's related to personality, whether it's related to genetics. So there's some variability. So that's kind of what I spent my time looking at.
Well, if low dose amphetamine give people a feeling of well-being and maybe some confidence, what is the problem with them as antidepressants that you can share with us? And why have they gotten such a reputation as being dangerous, causing weird behavior,
Yeah.
etc., as we well
Yeah.
know?
Yeah. It's interesting that you mentioned them as antidepressants because they were originally prescribed and they were quite effective as antidepressants. Then it became clear that they could be misused and that people could escalate their use and take higher and higher doses. And that leads to terrible, as you probably know, amphetamine psychosis and compulsive behaviors. And so I think their potential for abuse or misuse then led to limitations for their therapeutic use. Interestingly, that hasn't been an issue in the administration of amphetamines for ADHD. So for some reason one of the things they do is give the drug kind of a slow release so that then you don't get these high doses and people don't kind of escalate their use. So the amphetamines were withdrawn, and now they have a reputation for as being drugs with a high potential for abuse, which they do have, but there might be ways of coming around that for as an antidepressant.
As I recall, the Germans used amphetamines during World War II to develop what they called supermenschen. They thought they would get special soldiers that would have extra energy and so on. Is that still going on in the world? Are some countries still feeding that you know of? Are they giving soldiers amphetamines in order to enhance their feeling of confidence and ability on the battlefield?
I'm not sure about a battlefield, but I know that stimulants are used by pilots to maintain vigilance. So what they're very effective for is people have to stay very attentive and vigilant for their job, and amphetamines are widely used by pilots for that reason. And it's one of these things where it's not an indication, it's not an approved indication, but it's a common usage.
Is Ritalin technically an amphetamine?
It's close to an amphetamine, yes.
And the reason I ask about that is I spent 10 years of my 64-year career in chemical dependence. I started an international chemical dependence program. It was called Koch Ender's Alcohol and Drug Program. And what I found was a noticeable percentage of my adult patients had started with Ritalin as children. And many of them raised the question of the relationship between their having been given Ritalin and their later cocaine addiction. And I thought that was a very interesting connection to make.
It's an interesting observation, and it's been a point of controversy whether administering stimulant drugs to people with ADHD then increases or decreases their risk for subsequent drug misuse. And generally, the latter has won out. That is, when people are not treated for ADHD, they do a lot of acting out and a lot of maybe inappropriate behaviors, including drug use. So the consensus, as I understand it, is that they're better off controlling their symptoms with the medication, and that overrides the benefits of that override the small risk of them developing other problems with drug use. I don't doubt that you saw it and that people reported it, but the evidence seems to be that there isn't a substantially greater risk of drug abuse after Ritalin use.
And better to use the medicine to control the severity of the symptomatology of the ADHD than to go without it and have to deal with the severity of the symptoms.
Exactly.
Okay, so now moving more into the present, about 10 or 12 years ago, you moved into psychedelic science. And that was a big step for you because you're at a prestigious University of Chicago, and you're a well-known researcher. And 12 years ago, the psychedelic renaissance had not begun yet. And Roland Griffiths had already done his work down at Johns Hopkins, of course, on psilocybin. And I had done a very long-running series way back 15 years ago on psychedelic science, which helped, contribute to getting things going. But still, there was stigma attached. So to begin with, when you first started approaching and going into psychedelic science, in all candor, did you get eyebrows lifted at the University of Chicago? Or was there any outright stigma attached to your work, or how was it?
I guess I have two answers to that. One is that there were kind of two steps. One is moving from amphetamine to MDMA. So MDMA is technically not a psychedelic, but it does have it's sometimes classified as what's entactogen or empathogen. It somehow produces these unique effects that makes it useful in therapy and that kind of thing. So I made the transition from amphetamines to ecstasy or MDMA. And then the transition to LSD, someone just brought it to my attention that people are microdosing LSD. And I thought, I have the lab, I have the setup and the equipment and the relationship with my institutional review board to be able to do that. I was very nervous about doing LSD research to begin with for the reasons that you say, because of the stigma. And so I played it down as much as I could. And actually, one of the things that I did was I called it a study about serotonin agonists. So I named the drug, of course, I have to, but I did not want to draw attention to it. The approval process of getting the study started probably took about 2 years. So that's one thing that you have to know about doing psychedelic research, is that you need infinite patience But then in the end, the DEA and the FDA and the Institutional Review Board came around when I gave them assurances. Of course, I had a record of doing drug research over a long period of time, so that made it a little bit easier for me. But then eventually I was able to do it and get into it. And it's just a privilege and just a really exciting new field.
Okay, let's take them one substance at a time. You started out with MDMA, which, as you point out, is correctly, of course, is technically not a psychedelic, but it's close. And those of us who have self-experimented with it know that, particularly in higher doses, it can be, at least somewhat psychedelic, you might say. Uh, Share some of your findings on MDMA with us, please.
All right, my pleasure. So we set out to see how is MDMA different from other amphetamines. And so we could look at, there are a number of standardized measures to look at emotions and emotional connections. So that's the kind of thing that we did. So we had a whole series of studies. First of all, do people report feeling more sociable? Do people report feeling more loving? So we can get self-report measures. And indeed, people feel more empathic and more connected with other people just by their verbal reports. Then we can use a task where people are rejected from a little social game. It's a computer game where they play a game with another partner, and then they initially get accepted, and then they get rejected, and we measure how rejected they feel. And it turns out MDMA reduces the feeling of rejection, so it dampens negative emotions in that way. And amphetamine doesn't do that. So we're looking at what measures are MDMA and amphetamines different on. We also did a measure of physical touch, soft touch. So it turns out a lot of people who use MDMA report that they have a change in their sensation of touch. So there's a standardized way of measuring slow touch, which is social touch, or faster touch, which is not social touch. We want to know whether MDMA would increase the pleasantness of social touch. And it did. And again, MDMA increased the pleasantness of slow stroking on the skin, and it didn't change fast stroking. And amphetamine didn't do that. So it has a sensory component. And then I'll just tell you a third one was we look at people's responses to emotional expressions in other people's faces. So we show them angry faces, happy faces, sad faces, fearful faces. And basically what you do is start out with a neutral face and give them gradations of an emotion. And it turns out that MDMA makes you less sensitive to negative emotions in other people's faces. So that would mean if I sort of see you frowning, then the MDMA might, there you go. The MDMA might lessen that. It might make it more like a smiling face. So that might be helpful if you're being social and you want to interact with people and you're afraid of being judged, for example, that it might dampen their negative, the perception of negative emotions. And it might also help in therapy, for example, if you're telling your deepest secrets to somebody, to your therapist, but you perceive this kind of frowning expression, whether it's there or not, that might inhibit you. If you perceive less of the frowning, then you might be more willing to disclose. So those are some of the tasks that we've used to show that MDMA has something unique that's different from amphetamines.
Well, I see the positive aspects that you're putting forth. I'm a bit uncertain about the downplaying of what might be perceived as negativity, because if a person is frowning at you, and instead of recognizing they're frowning at you, you see it as something else, in a way, you're denying an important communication message. What's going on that they're sending you a frowning message and you're ignoring it? And so I'm wondering now, we use MDMA in couples therapy quite a bit. I think that's one of its most powerful places. But you're bringing something forth that I wasn't aware of, even with my vast experience with MDMA, which is the lack of recognition, if you will, or the lack of receptivity of a negative communication coming at you. And from a certain perspective, properly identifying a negative communication is as important as properly identifying a positive communication. Because
It's a very good point. I get it. I understand it. And I think that there are situations where it would not be appropriate to use, or it could interfere with functioning. For example, the drug could be misused in that respect. It could be used for sort of negative purposes if people are trying to convince you of something. The drugs are powerful, and the effects are not all positive. And I agree with you that could put you in a bad situation if you're less sensitive to negative expressions and subtle forms of communication. On the other hand, it might help you to get over a negative perceptions, or that come partly from you, that you're constrained by your own negative perception of the world, and so it might give you some new insight. But I think you're right that you have to be careful with these drugs, that they could be also have detrimental effects.
what can you tell us about a person's vulnerability to persuasion under the influence of MDMA?
It's a worry. I'm not an expert on this. It's a worry in the context of therapy. I think that the people who are doing therapy with MDMA are being extremely cautious because of the possibility of some sort of manipulation or inappropriate kind of connection between people. So it's a very sensitive area, and there is a chance that the drug could be misused if it's not limited to a kind of a professional setting, I would say.
So, for example, women who go to what's called raves or parties where MDMA is being given out, might these females be more susceptible to being taken advantage of sexually because they're under the influence of MDMA?
Yes, I think that's true, but I think it's also true with alcohol, for example.
Oh, well, definitely.
So, it's not something that's unique to this class of drugs. So,
No, but we're trying to learn about that. We know that's true of alcohol, that
right,
it loosens the governor, of course, and loosens inhibitions, and
right,
and it's used that way by
right,
predators and
right,
dominate. Right,
right.
but
So
now,
the MDMA would do it in a slightly different way, for example, by making people feel more connected with strangers, and then they might trust the strangers. It increases ratings of trustworthiness, for example. So it definitely has the potential to do that. And then, there are other classes of drugs that do similar things. For example, the benzodiazepines, for a long time, people were worried about roofies, Rohypnol and flunitrazepam, basically. And so that's one that it changes your inhibitions and also affects your memory. So there are different ways for drugs to be misused in those contexts.
so overall, sitting there now, what do you point us to as an area of either further research or best use psychotherapeutically of MDMA?
I think there are many questions. I think a lot of the lab studies that have been done with very healthy people. And so one question that comes up is, when the drug is being used more widely in a broader population, are there worries if the people have pre-existing psychiatric conditions that could be worsened by the drug, for example? That would be one area. Another area that's of great interest to all of us is how the psychotherapy interacts with the drug. So people believe that it's not just the drug alone that has the beneficial therapeutic effects, but and not the therapy, not the psychotherapy alone, but somehow the combination of the drug and the psychotherapy, that it makes the drug helps make people more open to talking or interacting or working with a therapist. So that's an understudied area. I think we don't know what the best therapy is to go with it, with the drug, or how often or how long, all those things.
In the San Francisco Bay Area, near where I live, therapists are using MDMA in conjunction with psychedelics for psychotherapeutic benefit, hopefully. Might you care to opine on that interaction?
I have no knowledge of systematic empirical studies that look at those combinations or the timing of them or the circumstances under which it's new territory that people are trying. And, that's one of the possible risks of making the drugs widely available, that people are going to try all kinds of things like combinations of drugs that might not be the wisest thing to do. So as far as I know, nobody has looked at that under controlled circumstances with controlled doses.
Thank you. Please opine to us about both methamphetamine and MDMA with regard to cardiovascular issues.
I'm not an expert in that. I know that both drugs increase heart rate and blood pressure, and if we certainly exclude anyone who has any cardiovascular problems before they participate in our studies.
Well, that's important to tell us right there. You're telling us that you exclude people that have any cardiovascular issues from your MDMA research. So
yes.
that means people who have high blood pressure, even though it may be under control from medicine, they would be excluded?
Yes. You need to understand that we have sort of an abundance of safety. We have a lot of safety concern. We're giving it in a controlled hospital environment. So we have to be very careful. But we would not give a drug that increases heart rate to someone who already has a high resting heart rate. Right.
And what about a person who's had AFib or tachycardia?
No, we would not do it.
If a person's had AFib, they would be excluded.
Yes.
If a person's had tachycardia, they would be excluded.
Yeah, it depends on the the setting, but yeah.
Yes. So you're being super careful in that regard.
Yes.
Very important to know. I know this is an unusual question, and you're welcome to not answer it if you don't want to. Do you care to make any comment based on your research on MDMA, what it was like for those people in Israel who were under the influence of MDMA when they were attacked and slaughtered?
I can only repeat what I've read in the newspapers, that for some people, the drugs seem to dampen the unpleasantness of the experience, and for other people, it worsened the unpleasantness of the experience. So people are doing follow-up studies to see whether there are lasting consequences. It's not that controlled. You don't know exactly. It's a kind of a qualitative report. So
yeah.
I think we've heard both reports, that it made it more unpleasant or that it made it less unpleasant.
Thank you for that. Okay. We talked a little about methamphetamine, a little bit about MDMA. Now let's move into the psychedelics. Where did you go from MDMA into the psychedelics?
A graduate student told me people are doing this microdosing, taking very low doses of LSD, and they're reporting all kinds of beneficial effects. But no one had really looked at it systematically under controlled conditions, and that's what I do. And so, and in particular, I am able to give the low doses of LSD without telling people what they're getting. So they're recruited for studies in our laboratory, and they might qualify for any of a number of studies, and where they get different drugs. So we were able to recruit people and say, you're going to be in a study, you might get a stimulant, a tranquilizer, a psychedelic drug, a placebo, or alcohol. So we give them a whole list. So that's really important because it minimizes the expectancies that we know influence people's responses to drugs. And that's been a challenge for interpreting the microdosing, the reports of microdosing. So nobody out in the real world microdoses without having some expectation that it's going to have some beneficial effect. So everybody who does it has some expectation. In our study, we can administer the drug and look at the pharmacological effects of the drug under conditions where they don't have any expectations of what they're going to experience. So then we want to know, well, what does it do? What doses? And so first of all, we looked at different doses. We started with a very low dose and middle and higher just to see what the threshold of the sensitivity was. And so we came up with a dose that was just around what was detectable.
Give us some numbers of those to apply to those dosages, please.
Okay. The doses that people take to trip are 100 and 200 micrograms. So the doses of LSD are extremely small, which indicates that it's quite specific. That usually you give drugs in milligram doses, and alcohol we give in grams per kilogram. So alcohol you give this is in micrograms. So the dose you have to have a real psychedelic experience is 100 to 200 micrograms. We were giving 6.5, 13, and 26 micrograms. So we're at about a tenth to a quarter of the tripping dose.
Okay. And what did you find was the subsensate cutoff point for most people?
Yeah. Well, that's the critical part. When you say most people, it turns out there's quite a lot of variability. So the one person's response at 26 micrograms might be somebody else's response at 6 micrograms. So there's a lot of variability, which makes it really complicated to study. So I would say that in the range of between 10 and 15 micrograms is around the threshold, speaking very broadly.
In my own personal case, I have found that 10 or 11 micrograms is subsensate. And once I get to 12, 13, or 14, I start to notice a little tiny tingle that tells me that I'm under the influence of something.
That's great. That's great. You've done very professional research on yourself there.
Well, I'm in the history of professionals who self-experiment over hundreds of years. We have people, as you well know, and I'm part of that group. And I try to do it in line with my training. So I've taken 9, 10, 11, 12, 13, 14, 15, all the way up to the number that you quoted, all the way up to 25.
Wow.
And at 25, it's not psychedelic by any means in terms of my inner consciousness or my perceptual field, but there's a lot of activity going on. I would liken it to maybe having made the mistake of drinking 6 or 8 cups of coffee, perhaps. It's a great amount of energy is moving through the system, is what it feels like subjectively.
Okay. So I'm especially interested in those low dose effects. When you get to very high doses, so many things are happening. You have visual things, you have emotional things, you have cognitive, distortions, that kind of thing. So I kind of hope that by looking at the very low doses, we can see what are the dimensions, what are the brain processes that the drug acts on as you go to higher and higher doses. So I'm interested to hear exactly your kind of report of what's the first thing to appear and then what grows with repeated with higher doses. Your experience with the feeling of energy is exactly what we're finding at these low doses. So when we start to see self-reported subjective effects, we see mainly feelings of vigor, energy, arousal, alertness. So those are kind of, we're not seeing distortions of any kind, as you say. We're not seeing any real emotional effects, and not really even mood, not really even feelings of euphoria, but this feeling of energy is the most distinctive thing.
Yes. And what I also notice is that when I go above between 20 and 25 micrograms, the feeling of energy is no longer pleasant.
I see.
It becomes unpleasant in higher numbers until going over a certain line, when it then becomes psychedelic, clearly, in terms of inner visualization and perceptual field.
Okay.
When it moves over into that psychedelic hyperspace, it becomes pleasant again. But there is that middle zone when it is not pleasant. It's almost like anxiety, because
Interesting. Yeah.
there's too much energy bouncing around, and it's not psychedelic and pleasant, but it's not subsensate. It's simply uncomfortable.
Well, it's interesting to hear this report from you because it sort of leads you to speculate that at low doses, it works on one receptor system. It might be something like dopamine, for example, but then at higher doses, it might work on another receptor system, for example, serotonergic preferentially. I don't know enough about the receptor mechanisms of those different doses, especially at very low doses, but it's sort of tempting to speculate that at a higher concentration, you start recruiting different receptors.
Now, can you share with us some of the measurements you're taking while people are under the influence of these low doses called microdoses?
Some of the measures are self-report questionnaires that we use for many other drugs as well. And that's where we see this increase in sense of vigor and arousal. We also there's one questionnaire that was developed specifically for psychedelic effects. It's called the 5-dimensional altered states of consciousness questionnaire. It's used with high doses, but we wanted to see whether these low doses would also affect this scale, and they do. So you get a very small increase on this 5D-ASC psychedelic scale as well. What other measures have we? I have also been doing studies with EEG. So on the EEG measures, we're looking at the brain's the neural response to a reward. So people either get delivered a reward or they have a loss, and we want to know whether the brain responds differently to reward. And we're using a technique where it's been shown that people who are depressed have a smaller brain response to receiving a reward. And so we wanted to know whether the low dose of LSD would increase people's responses to reward. And it did. And so this is kind of promising because we might be able to show this kind of effect even at doses where people don't report feeling a drug effect. So that's kind of like it's kind of like a holy grail for psychedelic researchers. Can you see an effect on the brain or maybe ultimately on behavior at doses that don't produce any detectable effect? So we have seen that the drug increases the brain signal when they get reward. Now, it happened at a dose that's just threshold where people, like your report, that they start feeling the drug effect at maybe 15 micrograms or something. So it's hard to say that we're really seeing this brain response without the subjective response, but that's something that we would work toward. The other thing I want to say here is that principle of having a change in brain function without a subjective report of feeling something is parallel to what you might see with an SSRI. So when people start taking SSRIs, they take the drug over a period of weeks and they don't really feel very much. They don't report this drug makes me feel high or stimulated or anything like that. They report not very much of anything, but somehow it's altering their brain function so that over a period of weeks, they start behaving in a way they have less depressive, less social anxiety, less depressed. So they start behaving differently. So I think that it's kind of an ideal to work toward. Is there something that can change the brain without any self-reports to begin with?
Well, it sounds to me from what you're saying like microdosing has potential as an antidepressant.
Yes. Yes, that would be the idea.
Now, when you studied amphetamines, you found very positive results at low doses, but it turns out there's a high potential for misuse or increased dosage or addiction. Do we have the same concerns about microdosing with LSD?
Not so much. The high doses of LSD, indeed, they produce this kind of mixture of very strong psychological effects, but it's not all positive. It's each time people report using the drug, they say you can't predict what it's going to do. It's a combination of good effects and bad effects. And so it's not something that people would do on a regular or compulsive basis. It's more along the lines of something people experiment with or use in their life. It's not something. And one direction we can look at for this kind of question is looking at animal models of drug taking. So for most of the drugs that humans abuse, so that would be heroin and stimulants and alcohol, many other drugs, animals will take the same drugs that people take. Psychedelics are an exception to that. The animals will not press a lever to get the psychedelic drug. So it seems to be kind of a uniquely human experience, and it's partly led by curiosity and self-introspection, that kind of thing. So it's not a drug that has potential. There's no such thing as psychedelic or hallucinogen dependence, for example. It just does. You don't become dependent on it. So in that way, it differs. Psychedelic drugs differ from amphetamines.
That's a very powerful statement coming from Harriet de Wit. It is. It's a statement that the government needs to hear, because
Right.
it is. It's saying that there is a certain built-in governor or safety with this particular classification of drugs.
That's true. That's true. It's not to say they wouldn't have some risks of their own, that with many drugs, they have adverse effects. So people might have bad experiences, but abuse liability, I would say no.
I think that's extremely important that the government know that.
Yeah.
Very low, very, very low, almost non-existent potential for addiction.
Yeah.
So,
Yeah.
and the animals won't press a lever to get it. I find that fascinating. Now, in my experience, what people refer to as negative experiences with psychedelics are almost exclusively the revelation under the influence of the psychedelic, which the revelation of very unpleasant material from the past. It's not as though some kind of weird stuff comes from out of nowhere, but more so material that's been repressed or suppressed has suddenly pops out of the box where it's been forced in order to protect the person, and it's been forced into the box, such as early childhood trauma or sexual abuse or various things like that. And they're suddenly confronted with it because it comes out. If they're in the presence of a trained person, this so-called bad trip or negative experience becomes the most positive experience, because they get to work on that demon and heal it and come away with a feeling of confidence and mastery. And they no longer have this unconscious sword of Damocles in their neck that, suppose that stuff that's stuffed in there pops out, which
Right.
which unconsciously they could be living with.
Right.
So
It's definitely, that's the report of many people, and from therapy situations. It's not clear that there are not also bad visions and bad experiences, like nightmare kinds of things, that aren't necessarily from their own lives, or that they aren't necessarily beneficial. So I think you could have both. You could have beneficial, negative, autobiographical experiences, but you could also have nightmare type of experiences, feeling that, I mean, in the end, just like a nightmare, you can always relate it to your own life. I don't know if you've ever done like dream work or something, but whatever is in the dream, if you work on it afterwards, even if it's kind of random thoughts and ideas, you can make something of it. What does that remind you of? How does that make you feel?
Yes.
Kind of thing. You can make something of it afterwards. But that doesn't necessarily mean that what the drug is doing is only erasing those and getting rid of those inhibitions. So
That's a point well taken. And yes, I'm a clinical psychologist, so
okay.
so I know what you're talking about with regard to the dreams. Um, I think this is a point extremely well taken on your part, that there are both demons that come out that can be healed with therapy, but there's also can be unleashed just random nightmares that are very frightening, so that people know they might face one or the other. I think particularly, we're not going to go into it today because it's not in your wheelhouse of research, but I think this is particularly true of ayahuasca, where where demons get unleashed, wild animals, snakes, jaguars, all kinds of things like that are very scary,
Yeah.
that are not necessarily representational of something that came out of the person's past.
Right. Right.
And that's an important point to make. Okay, what can you tell us about what's going on inside the brain under the influence of the psychedelics? Because you're measuring things like you mentioned EEG.
Yeah.
You're doing physiological measures, I gather, as well as questionnaires.
Yeah. People use that. They have wonderful technology to look inside the brain. They use functional magnetic resonance imaging. They look at connectivity between different parts of the brain. So how well those pathways are functioning from one part of the brain to the other. And they interpret those, but they always interpret them in relation to what we already know about what the subjective experience is. So there's, for example, a disconnection. So some regular pathways that are used a lot in the brain then become fragmented under the influence of the drug. So then you can say, well, that then corresponds. There's a temptation to say, well, that corresponds to the kind of feeling of openness and the feeling of loosening of boundaries and things. But those are, to my mind, those are kind of metaphors. We can look at brain function and we can describe what it does in the brain, but how to relate to that to the subject of experience is an art rather than a science, I would say. So you can look at whether the drug affects different parts of the brain. Does it activate something more or less? Does it change connectivity? Does it change responses to visual stimuli or rewarding stimuli? So I would say it's definitely worth studying how the drugs affect brain function, but we're not there yet. It's not going to explain to us how you have these powerful subjective experiences.
So, although I was, like yourself, trained in science, and I did teach for a while at the University of Michigan and Stanford, my career has basically been as a clinician, because I left academia. And so I'm listening to everything you're saying from the perspective of therapy and how any of this relates to what we might use in the office to help people.
Yeah.
And one of the issues that we're facing in therapy right now that I'm going to present to you, even though it's outside of your area of research, but I so much respect and value your opinion that I want to hear the answer to this. And one of the issues we're facing is, should a clinician who is engaging in the use of psychedelics with patients have experienced those psychedelics themselves or not? And it's a very big question, because the argument in favor of clinicians having the experience is, of course, they know the terrain and they've been there and they're comfortable with it, and they can even be more connected and empathetic to their patient. The argument against it is that the clinicians may do what's called go native and become sort of advocates in some way that's not proper or too much over the line. And it's sort of related to the issue you have of how do you give a placebo and also give the substance when the substance is so powerful that you know it right away. Although in your case, you pointed out that with subsensate doses, you're not having that problem, and that's a good point. But this question of whether therapists should have experience with the psychedelic before engaging in the therapy or not is a very big question nationally now. And I wonder if you might have a comment on it.
It's a good question. I don't have a good answer. I would say one caution is that one therapist's experience with a drug is not representative of what everybody's going to experience. So there's a risk there that that therapist's personal experience is going to some way influence their expectation of how the drug is going to affect the patient. And as you know, there's a lot of variability across individuals in how drugs make people feel. Some people makes them feel anxious. Some people feel calmer. So I would worry a little bit that the therapist, if we promote that idea that the therapist has to have used it him or herself, then I would worry that that's just one person's experience. And similarly with doses, what dose works for the therapist might not work for the patient as well. So it's a very, on the one hand, it's a rich body of knowledge to have to understand how it feels, and so in that way it would be a benefit. And on the other hand, it's also limiting because you think that's how the drug is rather than how it makes you feel. I guess I understand both points of view, that on the one hand, having some personal experience will help to put it in a framework and provide some reassurance, and then it provides also some warnings about what might happen. But there's also a risk that people will become proselytizers based on their own experience and then kind of push the idea. So I think the best you can do is to educate the therapists well, so that then whether they have used or not, they try to present to their patients as fair a view, a perspective as possible.
I'm aware of the fact that most of your research, when you talk about it, is presented at professional conferences or to other scientists, not to the general public. And I very much appreciate that you're taking the time today for this interview, which is going to go out more to the public at large. And with that, before we end the interview, what more that we might have missed or that you want to say can we share with the public at this time? What didn't we cover today of importance that we'd like them to know?
I think it's always important to put in a note of caution that these are powerful drugs, and that before we make them available to everybody under all circumstances, we need to be aware, we need to be responsible that they might have some damaging effects in some people, or if they're used repeatedly or at high doses. And even, so, and the sources of drugs is another big problem, that right now the drugs are not legally available, so you can't get them in the pure form. So you don't always know what you're getting. So I think to be responsible, we have to say to the general public, be very careful, about your sources, and about trying lower doses first before the higher doses. So that's one thing that I think. And I think the other thing is to be skeptical about a lot of positive reports, especially early on in a field like this. We get all positive reports. Like psychedelics work for everything that they've tested. It's worked for depression, it works for alcoholism, smoking cessation, end of life anxiety. We haven't heard any reports of things yet where it doesn't work so well. And so in that context, I think we need to be a little bit careful that we're still at a stage where it's kind of a sunny early on period, and there are darker things to be discovered yet. So to be cautious as before we push the field too quickly forward.
I think you'll be pleased to hear that my fifth book on psychedelics is entitled Psychedelic Medicine Adverse Effects.
Ah, good. What have you come up with adverse effects?
Plenty of adverse effects in very small percentages.
Okay.
Very small percentages, but definitely adverse effects with psilocybin, with ayahuasca, with LSD, even with MDMA, but it's a wide range of different adverse effects, certainly including but not limited to those with cardiovascular issues, as we've talked about on this program,
Right.
and people with certain pre-existing conditions, and
Right.
even those without. The thing that I'm finding most interesting, Harriet, is that on the one hand, while the percentage of adverse effects is extremely small, we know as scientists that when you apply an extremely small percentage to an extremely large number of people, you have a lot of cases.
Right.
And the
Right.
and the public can forget that even 0.1% applied to 100 million people is going to leave a lot of people with
So
adverse effects. So we
that's
have to be careful. I'm getting a signal here from our producer Charlie that we've got a few minutes left. So I'm going to ask you one last question. Where is Harriet de Wit headed in her research?
I would like to go on forever. I think that it's so fascinating to ask all these questions, and there are an infinite number of questions. I'm running out of time as far as writing grants and going through all the uncertainty of funding and that kind of thing. So I'm delighted to pass on the whatever it is, the guard to the next generation of people, and they're already doing a great job. So I don't have a clear next step.
Okay, fair enough. But just to let you know, I turned 85 a few weeks ago, and I intend to keep going for the duration.
That's fantastic. Congratulations. That's good to hear. 85. Wow.
Thank you. Thank you, Harriet de Wit, for being with us today on Mind, Body, Health, and Politics. It really has been my privilege, and I thank you very much.
It's been my pleasure. You have great questions. You have great stories to tell. It's just been a real pleasure talking to you. Thank you.
And thank you, gentle listeners, for being with us today on this broadcast of Mind, Body, Health, and Politics. I remind you that we broadcast every week. You can go to mindbodyhealthpolitics.org, and all of our archives are open source, no fee to you. That's part of our tradition.
True.
Also, you can go to Amazon and look for some of my books, Psychedelic Medicine, Psychedelic Wisdom, Integral Psychedelic Therapy, and coming out very soon, Psychedelic Medicine at the End of Life. Until next time, this is Dr. Richard Lewis Miller reminding you that good health is worth fighting for, and it's essential for life, liberty, and the pursuit of happiness.